Hi, welcome to the PEDSnet Data Analyst Training Series and to our session today on privacy, data security, and access to PEDSnet studied databases. I'm Charles Bailey. I'm a clinical informatician based in the PEDSnet Data and Statistical Coordinating Center, and I'm happy to walk you through this topic for today. So let's start by just defining some basic terms, right? So when we talk about privacy, what we're talking about is the person-centered notion of the ability to control the information about yourself. In particular, the ability to prevent private information or information that you don't want to be disclosed from actually being disclosed. When we think about privacy in a network like PEDSnet, we think about that applying in particular to patients and to the family members of patients. But it's also worth remembering that there is some level of privacy that applies to the healthcare establishment as well, to institutions who have an interest in protecting their reputation or business processes, to providers and to others who are involved in healthcare delivery. Data security is the more pragmatic term. So data security encompasses the things that we do to ensure that data are not compromised, that they're not disclosed in a place or in a manner in which they could reveal someone's identity or reveal facts about someone, that they are not shared for a purpose that's not legitimate, that they are not used in a way that's not consistent with their purpose. The idea behind data security is that it protects the privacy of individuals, but it also protects the confidentiality of information about individuals. So given those terms, let's talk about how we protect privacy for patients in PEDSnet or really in any clinical data set. The strongest way of protecting privacy is the concept of anonymity, right? So anonymity means that one record is indistinguishable from some other record. And we often talk about the concept of K-anonymity, where we say that a particular record is indistinguishable from K other records. So if we say that a data set has 5 anonymity, we mean that that every record in that data set has at least 4 other identical records to it, so that there's no way to distinguish one individual in that set of 5 from another. This is desirable in that it provides a strong protection against loss of privacy if K is large enough, because you can't make the distinction among the members of that K subset. In particular, because there is no difference between those records, it's very hard to reverse engineer the data set to get back to a single person's record. You can get here in a variety of ways, right? You can aggregate data. So instead of reporting on individuals, you can report on groups of individuals and use summary statistics so that each group contains a number of different people. You can reduce precision. So if you need records to be identical to each other and you have, for instance, a laboratory value that's different only in the second decimal place, you can round to 1 decimal place, and then those records will become functionally identical. Or you can use other ways to pull detail out of a record, dropping certain fields or rearranging data in such a way that you can get to a higher degree of anonymity. The catch here is that because anonymity relies on one record being fully indistinguishable from another record, you may actually end up removing analytically important detail if you take measures that get you to a higher degree of anonymity. Okay, so while anonymity is a desirable characteristic of a data set, it's often hard to achieve in complex clinical data. So more often we rely on techniques that produce de-identification. So this is the removal of things about a person that are unique and that are easy to find in other data sources. Classic examples would be a person's name or a person's social security number, or within a health system, a medical record number. These are facts about the patient that allow ready linkage to other sources of data and a fairly short path back to the kinds of identity that we are often interested in limiting disclosure of. So things like names and addresses. It's easier to achieve the identification because you're removing specific facts. But the thing that you have to be careful about is what constitutes an identifier for an individual may depend on the data set in question. For instance, there is literature that clearly establishes that 3 visits to particular specialists are sufficient to uniquely identify a person and actually to allow linkage between registry and claims data sets, right? So identifiers in this sense are not just the individual characteristics like name or like date of birth. They're anything that suffices to uniquely identify a person and allow that identity to be transferred between data sets. And having said that, what you need to be aware of is that as clinical data get more and more complex, the likelihood that there will be a unique fact pattern that identifies an individual in a particular data set, and that fact pattern will be replicated in another data set that shares data sources like the same hospitals or the same medical histories, is actually pretty substantial. And so there are a number of examples of data sets that were made publicly available with the thought that they were de-identified, that were then subject to analysis, leading to re-identification of large numbers of individuals. So that leads us to one of the privacy principles in PEDSnet, and that's that we consider all individual level data to be potentially identifying, whether or not it meets common regulatory standards for de-identification, which we'll talk about in a bit. So let's start with a broader picture of regulatory oversight, right? In the US, at least, there are two regulatory pillars for the way that we address the privacy interests of persons represented in clinical data and the kinds of data security measures that we take to protect them. The first is the Health Insurance Portability and Accountability Act, often called HIPAA. Right? This is a general statute that deals with the privacy of healthcare data, both for healthcare operations and for use in research. It focuses on the presence of specific identifiers in data to define what data pose more or less of an identity risk. Its companion in the research world is the Common Rule. And I say "and friends" here because the Common Rule applies to a number of federal agencies, but not all, although most agencies that are not covered by the Common Rule have their own set of regulations that very closely mirror the Common Rule. So the Common Rule deals specifically with research that involves human persons, and it's a little bit different from HIPAA in that instead of using a black and white set of identifiers, it focuses on the concept of what constitutes readily identifiable data. So let's dig into these a bit more. In the regulations that emanate from HIPAA and its companion act, HITECH, the rule that is most directly applicable here is the so-called privacy rule. The privacy rule specifies a number of levels of regulation around protecting individual privacy. This is based on the definition of what's called protected health information. So a set of identifiers that, if present, are considered sufficient to engage privacy risk, and if absent, are not. So that leads to a ranking of data sets. If any of the 18 so-called safe harbor identifiers, so things like patient's name, full address, social security number, medical record number, as well as characteristics that were potentially identifying when the regulations were adopted, such as automobile license plates or IP addresses, are present, then data are considered not to be de-identified unless an expert with an appropriate statistical background determines that in this particular data set, despite the presence of one or more of these 18 potential identifiers, there is no reasonable risk that an individual could be identified. At the other end of the spectrum, there's what the privacy rule calls a fully identified data set. And that is defined as any data set that contains personal identifiers with the potential exception of dates or zip code level locations. Right? A fully identified data set requires either the authorization from each individual in the data set to use the PHI, or a waiver from an appropriate privacy board, or if the data are being used for a business purpose, the presence of a business associate agreement. In between the two, there's this entity that the privacy rule defines as a limited data set. So this contains none of the 18 designated identifiers except for dates and locations that are roughly equivalent to a zip code, so not full addresses. There are some limitations on the way dates and ages can be represented, but they're generally not a major factor in PEDSnet. So it's at this level that actually most of PEDSnet research is conducted. In general, data sets will have dates present because they are often necessary not only to establish the age of the patient, which is a critical characteristic when doing pediatric research, but also to establish things like seasonality or secular effect and in studies of infectious disease or other quantities that change over time. The final thing to say about the privacy rule is that it applies at the level of data sharing. So it applies in what it describes as disclosures of data. It doesn't treat research in a particularly different way, except insofar as it notes that this is separate from the business of operating a hospital. All right, on the other hand, the common rule deals specifically with research that involves human subjects, right, or human research participants in the more modern language. It's intended to establish broad oversight and ethical supervision of research that involves, in particular, living persons. And it vests this responsibility institutionally in IRBs, or institutional review boards. In the common rule, the standard for what engages risk of privacy is whether or not data are readily identifiable. And readily identifiable is not further defined, but is a property both of what's in the data set and how identifying that information is, and how much work someone who has the data set would have to go to in order to establish a person's identity. So to pick an example, a person's name would be readily identifiable. On the other hand, a uniquely identifying pattern of laboratory values is not considered readily identifiable, because even though the investigator might have access to a data warehouse or an electronic health record that contains those lab values, and might with enough effort be able to track down which individual in that database had exactly that sequence of lab values, that is not readily identifiable. It's also worth noting that in the common rule, the standard for assessing risk to persons who are identifiable is whether they could be subject to physical injury or harm, psychosocial injury or harm, and economic injury or harm. So again, the question, even if a person is identifiable, is will the data that are available subject to them to one of these risks? And if so, that triggers an increased level of scrutiny. Conversely, there is a reduced regulatory burden for studies that are designated minimal risk, so that don't engage one of these particular risk categories. And in particular, in the current common rule, there is a provision made for secondary use of clinical data, so data that were obtained during the routine process of patient care and not specifically for the research, and were obtained and are managed by a HIPAA-covered entity. So in these circumstances, there are minimal requirements for IRBs to provide oversight or for investigators to provide detail in the ways in which the data will be used. So based on these regulations, PEDSnet has adopted a number of conventions that are derived from discussions among the participating institutions, including IRB representatives, privacy offices, and legal counsel. First of all, there is a master data sharing agreement that is part of the overall PEDSnet participation agreement, and that covers the use of limited data sets derived from central network data or from other sources within the network among PEDSnet members. So if you are working on a study that involves PEDSnet institutions and that study does not exceed the level of a limited data set, then there's no additional data sharing agreement necessary. That's covered by the PEDSnet Master DSA. That document is generally signed by institutions or institutional representatives. What we do in the network is take the most important terms from the DSA regarding individual privacy and replicate them in what we call the responsible use of data agreement. This is something that any person who is going to use individual level PEDSnet data is asked to sign, less as a contractual document, but then as a reminder of the kinds of principles, which we'll talk about later, that are part of the DSA and that we expect people to adhere to when using PEDSnet data. From an IRB perspective, studies that use only the core network data where most identifiers are missing and there has been two levels of coding introduced in order to separate the data in the core database from identifiable EHR data, are considered not human subjects research. So those are things that are not subject to ongoing oversight by an IRB and do not require submission and review of a complete protocol. For data that does reach the level of readily identifiable but presents minimal risk to patients, there is also a master IRB protocol that covers studies and offers the opportunity to provide oversight for a study by amending it onto the master protocol rather than having to resubmit and re-review each study. This is a significant advantage for study teams, partly because it saves some of the local overhead of review, but also because this master protocol is part of a reliance relationship across PEDSnet. So that means that when the process of amending a new study definition onto the master protocol is complete, that amendment is then shared by all of the institutions in PEDSnet rather than requiring processing at each of the individual institutions. All right, I want to pause and just talk a little bit about the process of linkage, because this is a critical element of many studies. So we spent a lot of time in the previous slides talking about how we set up data without a lot of identifiers in it in order to reduce the privacy risk to individuals. But then we recognize that in many study designs, it's important to be able to connect different sources of data, to take data that were derived from the EHR and line them up with data that might be in a registry or that might be in a set of adjudicated claims, so that you can follow in an analysis from, for instance, highly detailed EHR data about care in network to less detailed data in claims, but information about services that may have been received or care that may have been delivered out of network in order to get a better sense of what's going on overall with participants in the studies. Because most individual identifiers are not present in the PEDSnet data, clear text linkage, so the process of lining up names and addresses, for instance, or social security numbers, is not really an option. What we do in PEDSnet is adopt one of two alternate processes, which you'll hear more about in the future. Right? The first is something called privacy protecting or privacy preserving record linkage. The principle here is fairly simple. Each institution from which the data originates knows things like patient's name, date of birth, address, other sorts of characteristics. And what we want to do is try to link data based on those identifiers, but without revealing those identifiers outside the originating institutions. So the way PPRL works is that each institution goes through a process of irreversible encryption that reduces these individual identifiers to a series of strings of data that are not easy to link outside the data set or outside the process of PPRL. And then the way records are linked is that those encrypted strings are matched to find which patients are the same without ever having to know the identity of the patient. There are several technical safeguards built into this process to make it more difficult to perform this kind of linkage in a place outside the intended environment for linkage. And so in the end, this actually turns out to be quite a secure method of being able to establish when the same individual is present in the two data sets without knowing a whole lot about the identity of that individual. The other approach we've actually already talked about, in that I have spent some time pointing out the risks in the identification of so-called fact-based linkage, so that the recognition that there may be a unique pattern of facts in the data set to an individual that could be replicated in another data set, such as visit dates and specialists, or such as a series of lab values. Right? This is most useful where there are no identifiers available, and even PPRL is not an option. Right? the goal here is to use that unique series of facts to predict shared identity across the data sets. Again, without ever knowing something like an individual's name or date of birth, but knowing that the same series of events or series of values happen in both places. So this is very likely the same individual. This can be very effective, right? So what we're showing here is actually a linkage study that was done using PEDSnet data in which information about vital signs and laboratory values around the time of admission to an intensive care unit in the PEDSnet data were compared to a large national registry of pediatric ICU data. And what you can see here in this sort of classic receiver operating curve is that you can get to actually a fairly high both sensitivity and specificity of linkage by picking the right set of facts that are most informative about individuals around the time of admission, because they can take on a wide variety of values. And so the information content of each fact is high. And you can reach a cutoff where you have both a sensitivity and a specificity well over 90%, meaning that it's highly likely that in this subset of patients, if you see the same fact pattern in both databases, you are talking about the same individual, and you can learn something from each side of the link. All right, so that's how to get to data without risking someone's privacy outside the linkage. I also want to talk about some things that we do within the network to reduce the risk of privacy, even within network data. So perhaps the most common in study analyses and in reporting of study results is attention to small cells. So this, by small cell, we mean a value in a table or on a figure that is in itself aggregate data. So it's not talking about an individual, but it's talking about a very small number, and perhaps even an individual who just happens to be the only person or only few people who share those characteristics, who may have a particular diagnosis and be in a given age group, or who may have received a particular medication at a particular institution in a particular month. So what we do in PEDSnet is we remove values from tables and figures that are nominally aggregate data, but that risk identifying one or two or three individuals because the set of facts that got you to that cell in the table are shared only by a couple of people across the network. So our current threshold for what defines a small cell is fewer than 11 individuals. That's based on common CMS usage and fairly widely adopted in the field of clinical research. Particularly in areas like rare disease research, there is the possibility that smaller thresholds may be appropriate, but for large data sets like PEDSnet, we at least start with a value of 11. That number may go down for lower risk circumstances. It may go up for higher risk circumstances. And risk here depends not just on the clinical content of the data, but it may depend on what other information the particular cell conveys. For instance, a cell that contains 5 or 6 individuals because they share an age band that's 4 or 5 years wide. So there are 5 individuals between the age of 5 and 10 who have exposure to a particular drug, is potentially lower risk than an identical number in a cell that talks about exposure to that drug, but stratifies the patients by PEDSnet institution. Because in the latter case, you get a lot of geographical information about the patient by knowing at what institution they received the drug. So when we think about what the risk associated with these small cells is, we try to factor in both the substantive risk and what the stratification is telling us. The other thing that I will point out just as a very practical matter is we do require redaction of cells with a size of less than 11. And when you're doing this, you need to be a little bit careful about what you might or might not be revealing. For instance, if you have a column of cells and one of them is below 11 and you remove the number from that particular cell, but you also publish a sum of the column, then it's trivially easy to reverse engineer the size of the missing cell by just subtracting the other cells out of the column sum. So as you're doing this sort of privacy risk reduction in analytic results, you need to be careful to make sure that you don't allow for that kind of easy reverse engineering. Right, so while that's a fairly common technique for privacy risk reduction that's applied to the results of analysis, I also want to mention a couple of techniques that we use in the construction of study data sets that you may need to account for when you're conducting the analyses. So the first is a process that we call desensitization. So the removal of particularly sensitive data when it is not directly related to the analyses being conducted in the study. In PEDSnet, this refers to any data referring to HIV status, data referring to pregnancy or reproductive health, and data referring to many mental health conditions. There are a few that are so common that they're not automatically redacted, but most mental health conditions are also removed from a data set, again, unless they're directly relevant to the study. This is done using a series of standardized code sets, and those code sets are always available through the Atlas application. So if you are conducting an analysis and you want to see whether a particular code or codes may have been subject to removal as part of desensitization, you can always look in Atlas and see whether those codes are included. So while desensitization deals with specific types of information that have high social risk, we also try to reduce privacy risk in some more routine ways. We've collected a series of these into a tool that incorporates a number of heuristics we call less identification. So this obvious pun is pointing out that this is not de-identification, because we recognize that fact patterns may remain unique, but the idea is to remove some of the things that pose the greatest risk to privacy or risk to the separation of data sets. So this includes a number of heuristics. IDs that are common or stable across PEDSnet are taken out and replaced with single-use IDs specific to the study. The idea here being that we want to reduce the risk of accidental or unwanted linkage across study data sets, as opposed to with the PEDSnet main database or with EHR database. Because dates are one of the pieces of information that are particularly likely to facilitate linkage between data sets, the less identification process introduces date shifts, so we can preserve ages and we can preserve intervals between events, but we reduce the risk of anchoring events in time and thereby identifying a person in an unwanted way. Then finally, there are a number of things that we can do with specific values in order to reduce the risk that they'll be replicated between data sets. These include removal of values that may contain PHI or may otherwise contain information that's not helpful to the study, but creates privacy risk. Replacement of values where it's important to be able to track the presence of a given value, but the specific identity is not that important. So for instance, if it's important to track which patients come from the same site, but as I mentioned before, the name of the site provides a lot of geographic information, we can replace that with a label that identifies each site so patients can be grouped appropriately without necessarily revealing where in the country they live. Okay. So to give you an example here of less identification operating on a short synthetic data set, what you have here are two blue columns, person and visit occurrence ID. These are stable identifiers in PEDSnet, which means in the main database, from version to version, they'll remain the same so that it's possible to follow a patient over time. Those are replaced with study-specific identifiers to reduce the risk that different data sets become linkable. There are dates in this data set, and what less identified does is it replaces the dates using a patient-specific offset, but in a way that preserves the intervals between dates. Right? And then finally, you see here an example of site in the data set, which is important to connect patients who received their care in the same place but the analysis may not need to know what that place was. And so the tool can replace that with relatively less informative labels that still allow aggregation of the data. Right, so that gives you a background on some of the technical process. That's paired with policies in PEDSnet or rules of the road for use of PEDSnet data. There are some do's here, right? So study databases contain the minimum necessary data. It's a term of art that means that data that are related to the study are typically included in study data sets. Data that are unrelated to the study are not included. In particular, we generally don't try to create data sets that follow the pattern of all of the data for patients with condition X, right? We do expect databases will follow the privacy risk reduction practices when a study is designed and when a study is reviewed for execution in PEDSnet. Part of the discussion can be around whether some of those risk reduction practices may not be appropriate for the study. For instance, if this is a study that is focused on behavioral health outcomes in patients, then probably the routine process of removing behavioral health diagnoses will compromise the study's execution. And so we may need to modify that practice to account for the study's aims. There are some don'ts here too. So part of the agreement across institutions in the data sharing agreement and across individuals through the responsible use of data forms are that we won't re-identify patients outside the protocol. Right? So if a protocol calls for chart review, for instance, then it's perfectly reasonable and even necessary to re-identify the patient in order to find the appropriate chart. But we have all agreed that we will not take fact patterns from the data and try to take them back to the EHR or to re-identify a patient or look for identifying information in other data sets. We agreed to no sharing of non-aggregate data. And by aggregate data, I mean without small cell sizes. In particular, this includes sharing to public databases or to journal websites. And it is the policy of PEDSnet, for instance, that we do not provide individual level data along with the publication, but will provide alternate means for outside investigators to make inquiries about the results or the methods used in the study. We also agree not to perform bulk copying of data. So if we're using a database or a data set that's on a secured PEDSnet server, we've all agreed that one of the first things that we will not do is say, select star from and copy it all onto my desktop so that I can analyze it locally. Right? That does create some inconvenience in that you have to be in the secure environment to analyze the data, but it also allows us to ensure that the privacy of individuals is protected to a higher degree of reliability. So what does the process look like for this? When a study is first reviewed in PEDSnet as a concept, then there's discussion of the general types of data required. This is a study that's going to use medication data and diagnoses. This is a study that will be assessing behavioral health outcomes, and so we'll need to use that type of data, right? But generally at the concept review stage, we're not dealing with a detailed analysis plan. When we reach the study participation stage, so this is usually after a study is funded or has been contracted, then specific data requirements are set out so that institutions know what decisions they're making as they agree to participate in the study. This is the point where if we need to make changes in our privacy risk reduction practices, we have the specific discussions and seek permission from institutions to waive some of the risk reduction measures. It's relatively rare that a data set release is required. Generally, that's done if either PEDSnet data is being aggregated with other sources of data in a larger study, or if the analysis requires specialized analytic methods or analytic hardware that can't be reproduced in the secure databases at PEDSnet. When that's necessary, then there's a third level of review in which we ask a data release committee or an institutional administrative official at each institution whose data is represented in the data set to approve the release of the data. And at that step, the IOs are given detailed information about what data elements are present and what the size of the cohort from their institution might be or is approximately. Okay, so we've talked a lot about data security and ways to protect privacy of patients. Let's talk a little bit about actually getting to the data. And I'm going to talk in particular about two pathways to use PEDSnet data. The first is the Atlas web application. You'll hear more about this in a future session, but briefly, this is a web-based platform that is designed to allow you to interact with the data in lower risk ways without needing a whole lot of infrastructure set up around you or a whole lot of review in order to access the data. Atlas is useful for data exploration. You can do things like ask how many people in PEDSnet ever got a diagnosis of X, or how many people in PEDSnet ever took drug Y. It is useful for modeling cohort construction. It will allow you to apply different types of criteria over different time and look at attrition so that you, as you design your study, you can get an idea of how changes in eligibility criteria might affect your study cohort. And it will actually support a limited set of observational analyses. For most studies, though, the actual execution of the study is going to require more direct access to individual level data. And in those circumstances, we have a virtual desktop instance that provides access to data within the sort of security boundaries established by the PEDSnet Data and Statistical Coordinating Center and by other practices in information security and in information technology management, some engaging other parts of HIPAA that reduce the risk of data disclosure, reduce the risk of inadvertent breaches in the security of data. So in this virtual environment, each study has its data placed in a separate schema so that you can operate on your study's data in relative freedom from the risk of interfering with somebody else's study. All of these are housed in a Postgres relational database management system. So if you are familiar with relational databases, it will hopefully be a fairly easy environment to use. And access is provided via common open source tool sets, in particular, including the ability to interact with the data through programming in SQL, in R, or in Python. I will note, just as a practical point here, that I mentioned there is a separate schema so that you can read the data for your study and ideally not modify the EHR-derived data, but have the ability to create derivative tables or analytic tables. When you do this, one of our standards is that all writes to the database are done using a group role that is shared across the study team, as opposed to your individual set of credentials through which you authenticate to the database. That makes it possible for the members of the study team to interact in conducting the analyses. All right, so Atlas is housed in a publicly available website. You can see the URL here. I will point out that you will often, as you're using the application, find yourself connecting to it and getting this screen back. This is a reflection of the fact that there is an inactivity timeout on the application. So if you were using it previously and come back to it after too much time, it will tell you that it's failed to initialize. Right? And this just means that you're not signed in. If you refresh the page, you'll get yourself to the sign-in screen and you can pick up where you left off. The sign-in screen is fairly benign. It asks you for a username and a password. I will point out that, as with all PEDSnet data resources, two-factor authentication is required. So to access the data, you will need to be set up with the appropriate two-factor provisioning. Right? Once you're in Atlas, you can do things like explore domains of data. So what you're seeing here is a tree map of drug utilization in PEDSnet, where the size of each square in the tree map represents the number of patients exposed to that drug, and the shading of the square represents how many times each patient received the drug. So darker boxes tell you about drugs that people take more frequently. Lighter boxes are drugs that are administered less frequently. Right? You can see on the left, there are also a number of other tools that Atlas offers. We won't talk much about that today. since you'll have a whole separate session on how to become an effective user of Atlas. Access to the virtual desktop instance is via VMware's Horizon client through the connection information that we provide when you get your credentials to sign on. In particular, what you do is connect to the VMware server and look for a PEDSnet instance, right? Once again, two-factor authentication is required to connect. And then when you launch this instance, you'll be taken into a Linux system. I will point out, just as a practical matter, that sometimes just because of the way the screen renders, it can look a little cryptic during login. You'll see a prompt for a username and a password, but there's often not a lot of information on the screen until you've authenticated. I also point out that from time to time, you will see pop-ups asking you to authenticate as an administrator to update some aspect of the system. Feel free to ignore them, just dismiss them and continue with your work. Once you have authenticated to the VMware server and launched the instance, you'll be in a desktop environment that includes tools that we hope simplify access to the data, whatever your preferred language may be. So for instance, we have deployed the dbeaver SQL Workbench tool. You can see here that it allows you to define reusable connections by using the host and the schema information you're given as part of the study. I will point out, although I'm not showing the SSL details here, that all connections to the relational database have to be encrypted with SSL. So when you're setting up connection information, make sure you indicate that SSL is required. Once you have a connection defined, you can either use the tool to get information about table structure, where it will give you column names and data types, for instance, keys and indices, some basic statistics about the table. Or you can use a SQL Workbench to execute queries, and they will return results to you either by default in the application, or you have the option of exporting them to files. Again, remember that we're only exporting aggregate data. We don't do bulk copies through this tool. Okay. If SQL is not your thing, or if you're doing an analysis that operates better in other languages, you're welcome to use them. We actually prefer other languages for most study analyses because of the ability to do a sort of wider range of statistical modeling. So for instance, we provide connectivity through the R programming language. And what you see here is it's fairly straightforward to connect to the database in R and then say, in the table person, count the number of distinct person IDs for this particular database. That's a little over 8 million individuals. Or you can say, from the person table, let's connect to the names of dimensions. Look at the name associated with the race concept ID and count distinct individuals in each of the categories that this OMB-based value set for race concepts includes. And what you get back is a short table with count data there. All right, we'll go through more of this in both the discussion session associated with this lecture and in future sessions, but this should at least give you a flavor of what sorts of things you can do as you connect to the PEDSnet databases. All right, then, thank you very much for your time. I hope this was informative, and I look forward to talking to you in the discussion section.